and we're extremely pleased that you could join us this afternoon in December. We've got a great webinar for you. We're talking about trauma again, and we're going to talk about spinal cord injury. We're going to talk about traumatic brain injury, and then we're going to have a quick whiz around rehab and the types of rehab that we can have for those children. So I would just like to remind people that you can always join us as a member. All webinars will always be free and you're always welcome to join us. But if you would like to join the ISPN, we have a new amount, a new subscription, and we've managed to bring it right down. So I think it's 35, unless you are from an LMIC, and then it's been brought down to $10 per year. So please join us. And if anybody would like to join us in the committee, we're very happy. We'd love to hear from you. Please reach out at the end. I think Christina will leave an email at the end. So no further ado, I'm going to invite Ashley to speak. Ashley is one of the nurse practitioners at Dell Hospital in Texas in the US. And she is going to speak to us on spinal cord injury. Ashley, thank you so much for joining us today and welcome.
Thank you. Let me share my screen. Oopsies. All right, can you see my screen? You're good? You can see my screen?
Yes, we can.
Okay.
Yes.
Okay, great. So my name's Ashley again. I will be discussing pediatric spine trauma and key concepts. Again, I'm from Austin, Texas, at Dell Children's. So these are the learning objectives. We're going to talk about types of spinal cord injuries, common injury patterns, red flags, and then outline some diagnostic imaging and priority nursing assessments and interventions. So why pediatric spine trauma matters. So it accounts for 3 to 5% of all traumatic spinal traumas, with cervical spine being the most common. Early recognition and meticulous nursing care is very key to prevent any type of secondary injury. So here, as far as traumatic spine injury goes, it's either caused from hyperextension, hyperflexion, compression, or rotation. This usually results in some type of hemorrhage and edema that can impair circulation of the spinal cord and can result in ischemia. So the two categories is complete spinal cord injury, where you have total loss of sensory and motor below the level of injury, and then incomplete, where there's still some type of sensory and some type of motor below the level of injury, depending on where the injury did occur. So why are kids different? I have this little picture of a lollipop because it kind of reminds me how kids are: big head, skinny little neck. So their head to body ratio is a little off. Not off, but different from adults. And it takes a lot of higher torque to cause a cervical injury. And their fulcrum, meaning where they bend their neck as their infants, is usually at C2, C3. And as they mature into adulthood, it tends to start at C5 and C6. Kids' ligaments are a lot more elastic than adults. And their facets, meaning that the bricks of their spine are more horizontal than vertical, like they are in adults. And then their vertebral bodies are incompletely ossified as well. So here is an example of just a sagittal X-ray. So you could see here the child, how their facets are more horizontal and like squished, I guess you can say. And then as they mature and turn to adults, they look more vertical and look more like bricks stacking on top of each other. And that's usually around the age of 8 to 9. So common mechanisms that can cause spinal traumas. MVCs is obviously the leading cause of crashes. falls, as they get older and start participating in sports, recreation, football, rugby, gymnastics, trampolines, divings, the unfortunate non-accidental traumas and domestic violence, as well as, although rare, birth traumas and other pre-existing conditions that can lead to spine injuries. So usually the common areas of injuries for a pediatric patient is the cervical spine, like I had stated before, usually upper cervical spine when they're infants and young children, and as they get older, it becomes more subaxial, so C3 to C7, when they become older and become teens. Moving on down the line to thoracic and thoracolumbar fractures, those usually are caused from high energy traumas or some type of flexion injury. And then lumbar injuries usually are from the seatbelt. They can cause chance fractures, and those types of fractures they kind of remind me of an open tin can. So the vertebrae kind of do this number, and then there's 3 different types. And then lastly, skiwara, or spinal cord injury without radiographic abnormality. So these kids having some type of neurological deficit, but their x-rays and their MRI, their x-rays and their CTs usually have no findings of some type of injury. It does sometimes take an MRI to notice that there's some type of injury, but it does not always catch it. So when you see these kids that have some type of neurological deficit, treat it like it is a true spinal cord injury. These are just an example of the chance fractures that I was talking about. All right, so red flags and presenting symptoms is obviously the neck and back pain. So they'll have midline tenderness. It could be weakness, clumsiness, difficulty walking, numbness and tingling in their hands. And with extreme cases, it could be loss of bowel and bladder. And then any type of higher injuries, you start to think about respiratory, diaphragmatic, diaphragm injury and things like that. So as far as a focused neurological examination, you want to focus on first start with your ABCs, address that. And then before you move on to a very pertinent neuro exam, then you want to look at the spine and you want to inspect for the alignment, any bruising in the area, palpate for any tenderness, any step-offs. Those are things that need to be further evaluated and treated as there is a true spinal cord injury. You look at their motor exams, test the strength on each hand, note for any type of asymmetry, sensation. Here I have reflexes here. One thing that's more important to look at is their rectal tone. You can use a gloved finger with lubrication, check the rectal tone to see if there is any laxity there. There's also the bulbous cavernosus reflex. So this is just to check for sacral spinal cord. So how you look that is that you stimulate either the glands of the penis or the clitoris, and that should cause some type of contraction of the external anal sphincter. And any absence of this can indicate some type of spinal cord injuries. And it's always important to repeat your exams, make sure you're documenting any changes and noting for any type of subtle changes. So diagnostic imaging, the big thing is, can we clear the spine? Can we clear the spine? So if it's a low risk mechanism and they are absence of any type of clinical findings, as I discussed before, you should be able to clinically clear them depending on their age. Usually if we have something like that, we can ask the questions to if the child can participate to see if that's something we can do to clear their spinal cord, their spine. So there's plain x-rays. Usually a lateral view is a great looking at all the different vertebrae to see if there's fractures. Odontoid is also a good to look at the upper cervical spine, but to get a kid or a baby to open their mouth unless they're crying, to do that, it's not routinely done. There's flexion extension x-rays, and that looks at dynamic instability. So we look for any type of slips of the vertebrae. Also, then we would move on to CT scan, which is another quick way to look at any type of fractures or injuries or anything like that. So in the meantime, while we're waiting on these images, always keep them immobile. After that, then we can move on to an MRI, especially if we're having difficulty clearing the spine or the patient has a decreased level of consciousness. The MRIs are great for looking at the cord, ligaments, discs, soft tissues, and then also if you suspect a sciora. But every institution is different. Everyone has their own algorithm, how they do things. So I would look at your institution and how they treat that. And then also I put here that there's some congenital abnormalities that may mimic a spinal cord injury, but does not mean that it is true spinal cord injury. So as far as nursing priorities, always, like I said, maintain neutral alignment. You want to do log rolling of the patient, especially if they're full spine precautions. If it's a cervical injury, making sure they have a nice rigid cervical collar. You want to support their airway, monitor their heart rate, perfusion, frequent neuro checks, giving them adequate pain, because sometimes kids will guard, and knowing that if they're in pain, providing those type of pain medicines to allow them to get, so you can have a good exam. And then avoiding any type of secondary injury. You want to always assess the skin, make sure, especially when you have these braces on, that there's not any pressure points. You're checking their bowel and bladder, so initiating Foley catheter or intermittent catheterization, respiratory care, cystic cough, secretion management, and ventilator support. You want to prevent contractures, so getting PT and OT involved as soon as possible, as well as the rehab team. So these are just different braces. So we have the rigid C-collar here that the baby's wearing. This one in the middle is a TLSL brace, and then the furthest one is a halo brace. All different types of ways that we can immobilize our patients. So I wanted to touch on two things to look out for complication-wise for spinal traumas, especially these occur usually at T6 and above. It does cause a disruption in the autonomic system. So with neurogenic shock, it's a loss of the sympathetic nervous system. You may see hypotension, bradycardia, flushed skin, warm skin. And usually we treat this with atropine, vasopressors, or we give fluids. The other thing to look out for is autonomic dysreflexia. And this is when there is some type of stimulus that is initiating a surge in this sympathetic response, and that the body's not able to compensate with that. So usually the stimulus is somewhere below the level of the spinal cord injury. So think of like distended bladder, constipation, could be causing this storm. So the big thing about this is that you want to remove that stimulus. So whether that's to cath them or to disimpact them. So you may see high blood pressure, headaches, blurred vision, diaphoresis with vital sign changes. And then I just put this little plug in. Obviously, we're dealing with kids. You want to make sure that you're very honest and clear, that everyone's on the same page. You're not giving anybody false reassurance that what may be happening. You can involve child life, and then making sure that you have rehab early. So I have a little case study here. So we have a 5-year-old female. She has no past medical history. She was actually restrained in the back seat, but she was in a backless booster, so just the little seat that you put on the seat, and with a lap belt. She was involved in an MVC, and they were T-boned. She had no loss of consciousness. She did present with left shoulder pain and right-sided neck pain. We did obviously a slew of other things, but pertinent for this case, we did a CT of her cervical spine, and as well as a CTA. She was found to have a grade 2 left vertebral artery injury. So the artery that goes through one of your vertebrae was damaged. She did have a mildly displaced bilateral C2 pedicle fracture, or a hangman's fracture, and I have some pictures on the next slide. There was widening of her C2 and 3 of her vertebrae, as well as the interspinous ligaments were stretched as well on C1 and C2. So this is a sagittal CT scan of her cervical spine. You see here this big space here. Usually it's a lot closer. That lets us know that there's some type of ligament stretch or injury. There's also some spacing between the two vertebrae, as I had stated before. This is not like, this is just looking at the bones. So then I have a different view here. So this is an axial view where I have the red arrows at. So you kind of see the fracture here. Oh, let me go back. Sorry. The hangman's fracture the pedicle fracture, and then you can also see it here. So we went and took her to the OR. We gave the parents two options, whether that was using plates and screws or using a halo device. The parents opted to use a halo device on her because they didn't want to cause her permanent immobility. So we, on January 4th, we placed the halo. She wore it all the way till April. And then once we obtained images that showed that she had healed, we took off the halo, we put her in a cervical collar for 2 weeks. And then here's her progression. So this is pre-op. You can see her fracture here. Post-op, after she's in the halo brace, we try to get as aligned as well as we could. So it had really good alignment here. And then 9 months post-op and post the halo brace, fracture where? There's no fracture. It's nice and healed. So she is now moving. She's playing with her dog. She loves PE. She's a happy 8-year-old now that we used to see in our clinic. So she's a really funny girl. We think her parents cut all of her hair off because of the halo. So she has a cute little haircut too. So the key takeaways is always have a high suspicion that there's some type of spinal injury. You always want to immobilize the patient, look for subtle signs, repeat, and always document your neuro exams, and make sure that you are preventing any type of secondary injury. So here's my team, nurses, and all of our APPs in our hospital, and this is us at Halloween. But I'll look out for any questions in the chat. So thank you.
Thank you so much, Ashley. That was a great whip round and a great case study. Thank you. Ashley neatly reminded me that I had forgotten to tell everybody, and I'm so sorry, that if you have questions as we go along, please pop them in the question and answer box, and either any of us will answer or we'll direct them to whoever is speaking about what you want to talk about afterwards, and I can ask them. So I don't think we have any. Oh, we have nothing in the question and answer at the moment. So please feel free to pop that there. In the meantime, we're going to crack on, and Alison is going to speak to us now about traumatic brain injury. Alison is one of the surgical managers in São Paulo University Hospital in Brazil. So Alison, good morning, and thank you for joining us. And over to you. Thank you.
Thank you, Jean. Thank you for ESPN. And I go share my screen. Okay. I go talk about acute TBI, and I have no conflict of interest. Okay. We're going to see today epidemiology of TBI incidence definitions, the initial assessments, TBI classifications, neuroimaging exams, and the nursing process for the healthcare with this child. Again, TBI is the leading cause of death and disability in children worldwide. It's responsible for more than 75% of trauma-related childhood deaths. The closest injuries are the most common in childhood. The main causes of pediatric TBI vary according to the age group, but globally include contact sports, more common in older children and adolescents, violence, such as shaken baby syndrome, traffic accidents, particular car accidents, and pedestrian accidents. And domestic accidents is the winner for all TBI. And the main cause, especially infants and preschoolers, and neuromuscular development. Among children aged 1 to 4 years, and 82% of accidents, then causes of tip injury involved household objects, mainly falls for stairs, tables, and chairs. In the total, 40% of these head injuries are preventable. The definitions of TBI. Yeah, trauma that causes anatomical injury or functional impairment of the scalp, skull, meninges, brain, and blood vessels. The severity is determined and the initial assessment by the response of the Glasgow Coma scale. And he's divided into supratentorial and infratentorial categories. They can be open or closed. And under the localization, we have in the brain, the tentorium is a fold of dura mater that separates the cerebral hemispheres for cerebellum brainstem. The supratentorial lesions causes a mass effect and increased intracranial pressure, possible brainstem herniation, and motor cognitive and intellectual impairments. The infratentorial lesion affects the reticular activation system and characterized by pathological changes and vital signs. The brainstem, we have upper lesions cause the cortication in the children, and the lower lesions causes the celebration, as is more severity trauma. For initial assessment, we have the sequence of the normal sequence of trauma assessments, and like examinations, hemorrhages, airways, breathing, circulation, disability, and exposure. In our cases for TBI, we have more assessment for the neurological assessments, and with the severity neurological exam for the nursing and the medical team. In general, children under 2 years of age do not communicate verbally and require higher levels suspicion of injury, and the circumstances of accident of trauma are vital to determine the mechanism of injury and the potential severity of the injuries. And this is determined in our nurse care. And the classification, we use the Glasgow Coma scale. Remember, the light traumas is under 15 and 30 points, moderate trauma 13 or 9 points, and severe traumas less or 8 points of Glasgow Coma scale. To see the trauma, we have neuroimaging like X-ray, CT, MRI, and ultrasound. And thinking about fractures, you have some fractures, different fractures, like linear without depressions, gestatic fractures, comminuted fractures, linear but with depression, open and drillings trauma, and fracture of base of skull. And the base of skull, we have some traps because are not observable anatomic deformity in the pre-hospital care, are not detected with X-ray. The diagnosis is based on clinical findings and confirmed with CT or MRI. Are one high vascularized area. And the signs of this kind of fracture is the cerebral spinal fluid leak in rhinorrhea, in otorrhea, and the bleedings. We observe recognize beta signal and double halo, like these examples. And hemorrhages, they are classified as meningeal, parenchymal hemorrhages, and diagnosis is made around the ultrasound in the temporal window, CT scan, or MRI. To determine the severity, it's necessary to assess the extent and localization, and to stabilize the blending, we lower the patient's level of confusions. And okay, but thinking the localization of the hemorrhages, we can, under the skin and the bone, we have the subgaleal hematoma, under bone and dura mater, we have the extradural hematoma, under arachnoid and parenchyma, we have the subdural hematoma, and we have hematoma in parenchymas. more severity trauma. Remember, in the parenchyma hematoma, it has the mass effect because we have no expansion of the cranial cavity and accumulation of blood inside compact space with the brain, causing a compressive effect in the organ, and this requires a craniotomy for this compression. We have some diffusional axonal injuries, is another kind of trauma. This occurs when the skull subjects the rotation forces during deceleration and deceleration injury, most common in traffic accidents. We have trauma, contusion trauma, when the brain injury causes indirect trauma, usually associated with penetration or laceration trauma. And concussion is a diffuse brain injury accompanied by a brain loss of neurological function and most common in baby shaked syndrome. Okay, so what are the general symptoms of TBI? I make one classification and mute trauma with headache, dizziness, nausea, and hearing change. The moderate trauma with persistent headache, dullness, confusion, agitation, memory impairment, partial paralysis of the opposite side of trauma, range of linguistic difficulties, and severe trauma. We have low in the level confusionist, confusion, agitation, and coma. Okay, thinking in the nurse process to make the nursing care for these children, the preterm nurse must carry on the nursing process, which consistent in 4 distinct steps. When physical examination and analysis, the nursing diagnosis, the implementation of the health care, and evaluation. Remember, this is a continuous, and we have evaluation yearly to make another countings. And the clinical nurse care for non-surgical cases, nursing care is mainly based on the rigorous assessment of vital signs, rigorous neurological assessment, administration of prescribable drugs, support for injury secondary to trauma, water and nutrition support. For surgical care, we can take account the World Health Organization guidelines to safe surgery, choosing the operating room, defining the team, choice of equipment, a choice of instruments and supplies, and implementation of interoperative care. We use here in Brazil the checklist to surgical safety and good results. The recovery room, the surgery recovery takes place in a recovery room or in the UCI. In nursing care of this stage is observable the anesthetic reversal when application of a Gretchen-Kraulik scale and rigorous neurological assessments with early application of the Glasgow Coma scale, care devices like ICP, DREAMS, and CSF. In the case of this compressive craniotomy, strict carrying the surgical wound and with flap implantation in abdomen, and the continuous nursing care plan for the children. And the most common devices is CSF drainage, like being external lumbar peritoneal, and the ISP catheter. And the normal values for child is the 3, 4, 7 millimeters. This is my references. Thank you so much.
Thank you, Alison.
Thank you.
That was a great trip around brain injuries, traumatic brain injuries. And I would just like to point out that I was corrected earlier that the subscriptions are 30 for most people, and then the NICs are 15. So let's get that correct so that everybody knows how much they need to pay to join us. And now I am going to talk on a little bit on rehab. I'm going to cover both of the rehabs. And that means I have to share my screen and hang on a sec. I'm a bit stupid with this. It should say, whoops. I'm struggling.
Oh, Jenny, it's at the bottom. It's at the bottom of your screen, the share button.
Okay. I'm just going to, mine is running through it all on its own. There we go. Sorry. Having a moment. Can you all see that?
Yeah, we can see it. You can just make it a full screen.
Love to. Well, I would if I could. In presentation mode.
It is okay, but it is okay like that because it's well seen.
Is that better? No?
Actually, it is the same, but we can see it.
Okay, I'm sorry. Clearly stupid, and I was so late home from work. I missed out on the everybody telling everybody how to do it. Sorry. Okay, so I shall talk about pediatric rehab, and hopefully I will be in time, and none of us will be late. Okay. So we've already discussed the causes of TBI, but TBI is the leading cause of death and disability in children around the world. And SCI, spinal cord injury, although it's less common, it still results in lifelong disability if we have a significant injury. And in children, although we talk about the greater neuroplasticity, we also have the greater risk that if they have a traumatic brain injury, they may have developmental delay. And this can cause behavioral issues later, and it can also cause issues with being able to attend school or have a job. So it is extremely important. And when we talk about rehab, we have three main things about rehab. So we want to maximize their function and their independence. We want to support their cognitive, emotional, and social rehab, and we need to prepare them to reintegrate them back into home, school, and the community to be part of the community, whether that's their family, school, or around the neighborhood. So I'll look at spine first because we covered spine first, and you can see here, as was already discussed with Ashley earlier, much higher rate of cervical injuries within children compared to thoracic and lumbar. And when we look at spinal rehab and discuss the neurological level of an injury, we do this at least 72 hours after injury to allow for some of the spinal, the initial shock and also the initial swelling to go down if there's any hanging around. And we use the Asia scale. This here you can see helps to understand exactly what will happen afterwards, depending on where your level is and at what point. So whether we've got more than 50% motor or less than 50% motor. And for those who haven't seen it, the Asia scale looks like this. And the level of our neurological injury is defined as the lowest functioning nerve root that has intact sensation bilaterally. So it's got to be both sides. And a grade 3 or greater motor function bilaterally. So we're looking at 3 out of 5. And you can see there's it goes down through all of the spinal nerves. And just so that we understand, when we're looking at muscle strength, we're looking at whether we've got any muscle movement whatsoever. So there's either a 0, there's nothing, or there might be a flicker, right up to normal strength. And just thinking a little bit for you on the right-hand side. So C5 gives you elbow flexors. That means that you can move your elbows, and that means you probably will be able to use a wheelchair. And then as you come down the neck, you're going to get more into your hands and your fingers. And then further down the spine in the lumbar region gives you the ability to be able to stand and walk. And here we are just running through the Asia scale again. So if you're in Asia A, then you have absolutely no motor function at that point, and you have no sensory function either, right down to E, which is normal, and that would hopefully be the majority of us here and now. So prognosis-wise for a spinal cord injury, most of the recovery happens in the first 3 months, but there is a steady improvement usually over the first 6 to 9 months. Beyond that, it's much, much slower, and usually recovery plateaus between 12 and 18 months, and that's it. And no amount of amazing rehab around the world is going to alter this at this point. Now, I say that there are new things coming along. They're learning to start to plug electricity into people's spines, but at the moment, that's where we are. And I think this is quite nice because it just tells us when you look down your spinal injury, these are the sorts of things that you will have. So if you've got a C1 to 3, then you are going to be completely dependent. You're going to be ventilator dependent. You're going to have no movement, no sensation, no nothing below the neck. And we work down through, and you can see that in that case, you're going to need to either have a voice activated electric chair or a sit puff. And that's using with your ventilator. So as we move down, you can have an electric wheelchair if you have a C5, because you will have some flexion at the elbow and on down. So when we get down to the lumbar, if you have an L2 injury, then if you're going to put them in hip, knee, ankle orthosis, then they probably will be able to get a long swing through and walk in a very robotic fashion with some crutches of some description. As you come further down, then maybe you just need AFOs at L3 to get them up and walking. And beyond an L3, then probably they're going to be able to function and walk without assistance. I that we need to look at respiratory issue, pneumonia, to look at contraction, somebody who is unable. As discussed earlier, the neuro. Also, we need to. We are doing there for them skin breakdown because they can't fill the areas.
I think we lost her. Oh, there she is.
Yeah. I disappear for a minute.
Oh, there you go.
I'm back.
Okay.
So for rehab, I just go back one. So spine rehab consult in PICU often we get the rehab physician, PT, OT, maybe speech if necessary, eating therapy, dietary, and obviously child life and play therapy is extremely important. And our early rehab for these kids is early mobilization to help them up and get them going, focus on function. What can we get them to do? As we move through later, we got the same sort of people on board. You may want to include psychiatry as we go on. And we want to prevent secondary complications, pressure sores, respiratory issues, bladder and bowel issues, osteoporosis issues, contractures, and focusing on maximizing functional independence, getting them ready in adolescence to work towards a job, and eventually transition them into adult rehab as necessary. So you can see here we've got our domains: mobility and transfer, bladder and bowel, skin activity, respiratory care, spasticity. And these kids are often can be put forward have a high if they have a high injury, we may recommend them for ITB if they have a lot of spasticity. Moving on to TBI rehab, we've already caused the leading and as you can, majority of these are mild and they live and they all have no problems, and it's only the 10% that are less, and you can see that of the 10% who have a severe injury, discussed earlier, severe is 7 and below. Only 42% of them live, and of those, they're going to live with disability. In children, the prognosis is often good. The prognosis comes back quicker, but the cognitive prognosis can be quite guarded. And although they can look as if they're very well, when you actually put them into school and they have to concentrate and they have to actually work through them, they can have much more. And executive dysfunction is very common in our children. Now, sometimes they, as they grow, their deficit can become more obvious as a teenager than it was when they were a 6-year-old. So we're very keen in rehab to ensure that we do as much as possible for them early on. So you've all been through TBI rehab. Some things that are perhaps different from other rehab: low stimulation environment, quiet room. We limit visitors. We try very hard to get them back to a decent sleep-wake cycle. Sleep is very important for the healing brain, but it's also important to try and bring them back into a normal diurnal regime. A constant therapy team doing the same things, really important for TBIs because they need to have rhythm and they need to know what's coming next. Lots of memory aids out there for children who have short-term memory problems, and understanding the post-traumatic amnesia and procedural memory can help us help the children make their lives easier. So lots of impairments we see following TBI. Within motor, you can have spasticity, ataxia, weakness, or apraxia. Cognitively, you can have attention deficits, executive dysfunction, and memory loss. Behavioral, I think we've all seen this: impulsivity, agitation, irritability, mood lability, and sensory and communication problems, unable to speak, dysarthria, aphasia, dysphagia, and then you can also have visual changes and issues as well. Lots and lots of things here that you will see: cognitive problems, executive dysfunction, which we've sort of discussed already. We use the post-traumatic amnesia scale, the Westmead one, to help us understand sometimes whether this is a minor or a moderate injury, and how long they spend in post-traumatic amnesia will give us a good indication of what sort of a recovery they're going to make. And as you can see there, the longer that they remain in PTA, the more likely it is that they're going to have persistent defects, they're going to have issues in school, and maybe a more severe disability. We also use the Rancho's scale for cognition, and this allows us to understand a little bit more about how their brain is functioning before they're able to talk to us. So you can see when they're totally dependent and not doing anything, they're usually between a 1 and a 3. When they become confused, agitated, and start to wake up a little bit more and become a 4 and 5, this is when they're ready for really good intensive rehab. Before that, they're unable to join in or really make any good progress. And then you can see as we work through, you get up to a 10 when you are purposeful and appropriate, hopefully like myself today. Thinking of the agitated children that we see in rehab, there's various pharmacological things that we can do to help the agitation and storming that we see in brain injured children. I think probably the most widely used is clonidine, which helps to calm and quieten the children. You can also use various anti-seizure medicines that help to calm the patient as well as stop their seizures. And then if you need a little bit more, then you can use risperidone or haloperidol or benzodiazepines, but they can cause amnesia and they're not actually very helpful for children who already are having problems with their memory. So one of the biggest things for nurses is the family and social support in rehab. We try very hard to ensure that the parents are partners both in care and therapy. We have an ongoing education so that they're able to take over the care as the child goes home and gets better. Emotional and psychological care is very important. And as they get better, so moving them towards school may be important. They may have to move schools. They may have to drop a year if they've been in hospital a long time. Some places I know have a hospital within school that starts to integrate them earlier. And the nursing role is incredibly important. So the nursing role there to monitor for changes in neurological state, giving our drugs and educating our family, and then safety management. These children are, we've already discussed, are often impulsive, agitated. So safety management, ensuring they don't fall, looking after them if they're having seizures, and then education around looking after a child with TBI, all very important nursing roles within the rehab state. And we're looking at outcome measurements. There's all sorts of outcome measurements that you can use to see how your child is progressing. And as a rehab service, we want smooth transfer between the different services that are coming in and as we move them out of the hospital into education and community. Looking for when they come to rehab, they need to be medically stable and they need to be ready to partake and have a functional outcome. And we use SMART goals, as everybody does, to try for the whole family and the patient and the team to make goals that are appropriate for the children to achieve. The summary for rehab: early multidisciplinary and family-centered rehab will improve our long-term outcomes. We need to focus on the prevention of complications and the restoration of function, along with reintegration into society. We need to keep an eye on them. We mustn't let them slip the net. And nurses play a huge role in this, advocating for them, coordinating for them, and educating them and their families. So I thought I would just briefly share a very quick case study with you. This is a 4-year-old male who was involved in a car accident at speed. He was, like, unfortunately, many children in Qatar, an unrestrained passenger sat on his mum's lap. He was ejected from the car went under the lorry, and unfortunately, mum did not come out. When he was found on the road by the paramedics, he had a GCS of 3 and he had bleeding from his right ear. They intubated him on site there and put a C-spine collar on him and brought him to hospital. Imaging showed quite a mess. So he had multiple skull base of skull fractures. He had a retroclival, I can't spell, hematoma. He had an intraventricular hematoma. He had widespread grade 3 diffuse axonal injury. He had a left temporal contusion. He had a undisplaced C2 fracture. He had a right ossicular fracture. And he had deep grey matter restricted diffusion. So this was a massive C-spine and brain injury. And so he went straight from ED to the operating department, where he had an ISPN EVD put in with full neuroprotection in PICU. And he was in PICU for 10 days. He was extubated on day 8. PT were already starting to see him and starting to do some passive exercises with him in order to keep his limbs moving. By day 10, up on the unit, he was starting to open his eyes. He wasn't fixing and following, he was just opening his eyes. There was nobody at home. And he started to move his right arm, not in a productive or in a purposeful manner. It was just rhythmical moving of his hand, not seizing, but just rhythmical moving of his hand. And sometimes he would move his right leg, nothing down the left-hand side. And he had a constant eye deviation with a left sixth nerve palsy. So a month post-injury, because as we know, rehab for these kids takes a long time. He was starting to eat with the speech and language, and he was starting to make some noises. He was starting to consistently move both sides, but his right side purposefully and his left side not so purposefully. And 6 weeks post, he was starting to say a few words, mama, baba, and he was starting, the physios had him up and was starting to weight bear him through his legs. At 8 weeks, he was starting to have some purposeful communication. He was still very muddled at times, and he was taking full oral feed. So you can see that these rehab cases are a long way. At about 10 weeks, we moved him on to our rehabilitation facility for ongoing just rehab. He went with a C-spine collar on, and he came back to us at 5 months, where he was walking independently but slightly ataxic. The collar came off at that point. He still has a hearing issue in his right ear where he had the bone fracture, and he's going to need a hearing aid. He does have a mild persistent sixth nerve palsy, but he is managing to get around that. And I'm really pleased to say that from a cognitive point of view, he's done incredibly well. And he is about to start school after Christmas. He will be 5.5. He's 1 term late going, and I think he will do really well. So you can see you can have the most horrendous head injury and do incredibly well afterwards. Not all children do as well. So that's a quick stop around. I don't have any questions and answers. I don't know if anybody has a question they want to pop in there. What I would like to do is say thank you to Alison and Ashley for joining us today, and for such great talks. We have brought it in on time, which is great. This is the last webinar of this year. We have many planned for next year. I think we have 4 or 5 planned for next year. So please watch this space for the next one. And I will take this time to wish those who celebrate a happy Christmas later this month. And I hope you have a wonderful and safe new year, and see you next year. Thank you very much. And thank you, Christina, at the ISPN office for our Zoom. Bye.
Oh, it's cutting out. All right, thank you.